So we'll continue the session. So first, we'll start from page number 570. We'll continue the topic from page number 570. Jawaharlal Nehru National Urban Renewal Mission. That is the full form of JNNURM. Now, this is a very ambitious urban program in the history of India. Okay, it is a massive city modernization scheme. Okay, it's launched by the government of India under Urban Development, Ministry of Urban Development. And it was launched in the year 2005 for a 7-year period till 2012. Okay, to encourage cities to initiate steps for bringing phased improvements, phase by phase 1, phase 2, phase 3, like that. Okay, planning will be done on basis of the phases, and accordingly improvements has to be done in the civic service levels wherever public service is given. Okay, or those levels in phase wise improvements has to be done. Okay, so to encourage reforms, fast track any planned development. Okay, which cities have identified. Okay, make the urban infrastructure more efficient in terms of public transport and all, or any form of service delivery mechanisms you have, community participation. Okay, accountability of various agencies towards the citizens, that has to be efficient enough. It was a 50,000 crore rupees program for various cities over the next 7 years. Okay, it was actually launched in 2005, 2006 onwards, it was operating. Okay. Basic services to urban poor, these all schemes came under this JNURM. Okay. So it aims at creating economically productive, efficient, equitable, and responsive cities. Okay. That is the goal for the JNURM program. Just to make sure that social and economic infrastructure in the cities are upgraded. Okay, so when there is a upgrade in the infrastructure, when the infrastructure of the city is good, you can reach out to as many as population. The majority of the population can be covered. Okay, if the infrastructure of the city is not well planned, okay, a lot of population will get missed out on basic services as well. So to get in touch with the most inaccessible segments of the society as well, these programs will help. It is under the Ministry of Urban Development. So next we have the Sabla scheme for adolescent girls. So Sabla, under the Rajiv Gandhi scheme for empowerment of adolescent girls, under that Sabla scheme has come. Again, this is also a scheme for the empowerment of teenage girls, adolescent girls, and it was launched on International Women's Day in 2011. Okay, and it covers the girls who are within this age of 11 to 18 years of age. Okay, and now Sabla, and there is one more scheme, Poshan. Okay, Poshan Abhiyan. These two are integrated. Okay, and this also comes under the Ministry of Child and Women Development. Integrated this ICDS program, Integrated Development Services Scheme, Anganwadi centers. Okay, through them these schemes are implemented. Okay, because you have this scheme, the name of the scheme is there, But how does this scheme reach to the girls, actual girls who are in the school and all? Like, that is through the Anganwadis and ICDS. They carry out this scheme. They carry out other schemes as well. Okay, Anganwadis are these are Anganwadi centers, ICDS centers are the point of contact of target population and the scheme, where the scheme and the target population meet. These are the Anganwadi centers, ICD centers and all. So it improves the nutritional health, nutritional knowledge, health status through food supplements. Okay, and also teaching them various basic life skills, home skills, vocational skills, so that even if they drop out from school because of poverty or early marriage or any such social factors, it will not hinder their chances of being independent. Okay. So that is the Sabla scheme. Just a minute. And also to give them awareness about their health, sexual hygiene, menstrual hygiene. Okay, there is another scheme for that as well, the URSH scheme, that is adolescent reproductive and sexual health scheme. Provide them formal, informal education, and even give them guidance on public services. Okay, if they complete their high school and all, at least they can give the entrance exam for these public services and get a regular income. Okay. Then you have the adolescent friendly health clinics and the adolescent reproductive and sexual health scheme. Okay. So these adolescent clinics, okay, adolescent friendly health clinics, they will focus on reorganizing the existing public health systems in order to meet the service needs of adolescents. Okay, and also give them counseling, routine checkups, usually to rule out anemia or any SCDs and all, yeah, missed pregnancies or something like that. So routine checkups at primary, secondary, tertiary levels of care is provided on fixed dates and fixed time to the adolescents, married, unmarried girls, boys during the clinic sessions. And different names are used for these same clinics in various states. Okay, in Maharashtra it is Maitri, in Uttarakhand it is Udhan, and Karnataka it is Sneha, and so on. So different names will be there, but the functionality remains the same. The process, the guidelines, guiding principles of these clinics are the same. Okay, the main objective is to make sure the adolescents, teenagers are able to access the services given by these clinics. Okay, then you have the URSH training centers. All the healthcare functionaries are made sensitive towards the health needs of adolescents. Okay, and there is a training for 5 days for all the ANM nurses and staff nurses, 3 days for medical officers through any state institute of health and family welfare. These medicos can undergo the training to take care of or to be more sensitive towards the adolescents' needs, teenagers' needs. Okay. Then we have various outreach programs, okay, which give periodic health checkups at village health and nutritional days. Okay, they are conducted. So they are conducted to provide services to adolescent girls who cannot access the clinical based services. So not all adolescent girls, they are not that independent that they can on their own go to a clinic, okay, and get some services or some treatment or some counseling done. Usually a parent accompanies them, right? But in some cases where the parents don't support their children for health, or for various other reasons, they don't have the means of transportation to reach these clinics or to access these clinics, okay, or there could be some stigma attached to it. So in that situation, we have the outreach programs, okay. Then convergence to support adolescent health issues across the country. Okay, and getting partnered with various departments like Women and Child Development. Okay, WCD is Women and Child Development, and also the ongoing Sabla program. Okay, Sabla and Poshan programs are integrated under the Ministry of Women and Child Welfare. Okay, so these ministries can also help push the policies, principles, the functionality of ARSH program and the adolescent friendly health clinic programs. Okay. Then we have comprehensive national nutrition survey. So in this, in 2016 to 17, this program took off. Majorly to identify what are the situation nutritional woes that nutritional issues, woes means issues that we have in India. Okay. Tamil Nadu and Goa, these are the two states that had the highest number of adolescents who are either overweight or obese. Okay. Goa had the most obese adolescents as compared to all the other states. 10% of children and adolescents are pre-diabetic. 7% have the risk of chronic disease, kidney diseases. 5% have had high blood pressure. 4% had cholesterol from these uh, statistics. Okay. So from where do you get these percentages? How do you know 10%, 7%? So a national nutritional survey was done. Okay. So it measures various standard deviations on state, okay, based on the GDP of the state and all. State's count of overweight and obese adolescents is also means yeah, from the mean body mass index. Okay, so Z scores and all that these are statistics statistical terms. Okay, to understand the average and all. Okay, and to compare, make a ranking comparison and all. Z scores and all are checked. You don't have to go deep into it. Okay, Carl Pearson and all these different kind of tools are used to come out to a conclusion. So here you can see uh, which all states have the most number of obese children, or obese teenagers as well. Goa and Tamil Nadu have the most. Then you have Delhi, okay. Then Arunachal Pradesh. Then you have Kerala, okay. These are the states in which you will find the most obese teenagers. Also, malnourishment is also found, not just obesity, state of malnourishment. In Jammu Kashmir has the is the state that had the most number of stunting. Okay, and then Goa. Jammu Kashmir had the least number of stunting, means healthy children. Then Goa, Tamil Nadu, Kerala. Okay, Sikkim, Punjab, Himachal Pradesh. The most number of stunted growth in children was seen in the state of Bihar, Meghalaya, Madhya Pradesh, Gujarat, Uttar Pradesh, Rajasthan. So we have the Bimaru states as well. Bimaru is the abbreviation we use for Bihar, Madhya Pradesh, Rajasthan, Uttar Pradesh. So the malnourishment rate, anemia rate, what is the percent of the population in these states who are anemic, okay, or at risk of being anemic. So these things are determined by the National Nutritional Survey, comprehensive survey. Okay. These surveys are usually not as long as a population survey. It's much shorter than that. Okay, every 5 years and all they can conduct. Then you have the Nutritional Family Health Survey. So from this survey, you can get information for fertility rates of the country, how many infant mortality, child mortality happens, okay, the practice of family planning, maternal and child health, reproductive health, nutrition, anemia, utilization and quality of health and family planning services. Okay, these things can be found out. So it is done at district level, and also it is done at national level. Where district level, it covers all districts of a state in a phased manner. And at national level, more indicators of nutrition are also under check. Anemia and all at national level is done. Then we have the Poshan Abhiyan. So it is a multi-ministerial mission in which we are trying to make India malnutrition free by 2022. So the objective of Poshan Abhiyan is to reduce stunting in these specially identified Vimaru states and all. Okay. And making Anganwadi services more utilized. Okay. Making them work harder. Okay. And making sure that as many Anganwadi service centers can be put up, especially in Bimaru states. And that can lead to the holistic development of pregnant women, mothers, children, everyone. So Ministry of Women and Child Development, Poshan Abhiyan, is also implemented by the same ministry. So some key strategies that the Poshan Abhiyan has taken care of is the feeding for infant and young child through nutritional supplements, immunization, okay, pushing for institutionalized delivery, making sure that the children are born in hospitals or healthcare centers, facilities for water, sanitation, hygiene, deworming programs in which anti-helminthics are distributed at risk population, okay, ORS solution, zinc, food fortification, dietary diversification, okay, adolescent nutrition, maternal health and nutrition. So these things will come under the Poshan Abhiyan. Then you have the Lakshya program. So Lakshya stands for Labor Room Quality Improvement Initiative launched. Okay. It was launched in the year they have not mentioned. Okay. But Labor Room Quality Improvement Initiative means safe delivery. Okay. Now we have the mobile apps also to improve the quality of labor rooms. Okay. It can help managing deliveries, improve training, post training, through webinars and all, through mobile apps. Webinars and seminars can be attended, okay, by the medicals. To cover district and sub-district hospitals, to govern medical colleges and community health centers, provide support to conduct quality certification of labor room, incentives for achieving targets. So when you follow all these key elements, okay, you are moving towards reducing the preventable maternal and newborn mortality, morbidity, stillbirths, okay, which are usually associated during the delivery, okay, so you can prevent that. And ensuring a respectful maternity care, or at least encouraging good maternity care to the family and the mother, what things they have to take care of, any immunization and all. So usually this Lakshya program is implemented by medical colleges, hospitals that have medical college, district hospitals, FRU, the first referral units, primary health centers, okay, community health centers. They are the ones who take care of or make sure that Lakshya reaches out to the population. And it can benefit all the pregnant women and newborn babies who are being delivered in health institutions, okay, not home deliveries, okay, the not the birth given at home. So the quality improvement in labor room and maternity OT will be assessed through the National Quality Assurance Standards. These are the accreditations for government hospitals, like high private hospitals have NABH, JCI and all. Public hospitals have NAQ, NQAS, that is National Quality Assurance Standards. So these standards will be the guiding principles of quality improvement in labor room in these government setups. Then you have the Surakshit Matritva Ashwasan Suman program. Okay. It was launched in 2019, October. So again, it is a new initiative to prevent maternal and newborn deaths, just like Lakshya. Lakshya, what is the difference? Lakshya is focused on quality improvement in labor rooms. Okay. So here it is more than quality, just quality. Okay, so there is a zero tolerance for any negligence. Cases will be filed. Okay, if there is any negligence or malpractice, it integrates all the other schemes as well. Okay, Poshan, Lakshya, FRU, JSSK. These initiatives are also integrated into this one Suman program. It works for respect for women's autonomy, dignity, feeling, and choices. Okay, so MTP Act also takes care of, and 100% maternal death reporting and reviews. Each and every maternal death that took place during labor period or during the puerperal period as well has to be reported. Grievance redressal mechanism, because negligence will be gynecological negligence, obstetrical negligence will be filed through this. Okay, so they will make sure that complete redressal is done. Client feedback, awards to champions in healthcare, champion in maternal healthcare. And it also works with different sectors of the community as well, not just the hospital or healthcare, school, educational centers, medical colleges, training centers. Okay, they all come under examples of some intersectoral approach. So IMNCI, that is the next program, the integrated management of neonatal and childhood illnesses. So IMNCI is an integrated approach to child health, and it focuses on the well-being of the whole child. It focused primarily on most common causes of child mortality in India. It is diarrhea, pneumonia, measles, malaria, okay, malnourishments, uh, and this affects children who are especially just 1 week, 2 months old, okay, 2 to 5 year old, under 5 children. Okay, they are the most affected with child mortality. So it also has a triage system like pink, yellow, green color codes. Okay, and also for emergency triage assessment treatment, ETAT is followed here. So a very sick child like who has pneumonia, meningitis, or septicemia, they come under the pink code. Okay, because it is extreme illness. Red is the code for extreme illness, critically ill child. If the children have some clinical signs and symptoms of disease condition, they are marked as yellow. No clinical sign, it is green. And if the child is at danger, they will be marked as pink. Okay, that is the color coding system followed here. This triad system is used in emergency and ICU care. So it's usually a hospital-based, a clinical setup-based scheme. And there is a lot of checklist available for the IMNCI. Okay, making sure that proper medications are available, making sure that the workers who are managing the sick child are skilled. Okay, family is well educated about the child's condition, care seeker how they are behaving, how the family members are behaving towards the child. So checklists for all these topics are available under IMNCI. Some clinical cases are also given in the modification and challenges section. So that is more medical side, clinical side. That you don't have to read about. And then universal immunization schedule is also given on page number 602. You can just go through it. And 603, the schedule is given, the updated schedule at birth. BCG is given, OPV or polio vaccine. Hepatitis is given at birth. At 6 week, rotavirus, PCV1, IPV1 is given. Polio vaccine is IPV. Then at 10 weeks, diphtheria, hepatitis B, polio vaccine, rotavirus, PCV, second dose is given. At 14 weeks, also the same. 6 months, again, catch up for vaccination. Influenza vaccine can be started. 9 months, measles and rubella vaccine is given. 12 months, hepatitis A, thyroid, and typhoid vaccine is given, only if it is recommended, typhoid. At 15 months, again, MMR, measles, mumps, rubella vaccine. Then at 16 to 18 months, diphtheria, whooping cough, polio vaccine. Hepatitis, 18th month, hepatitis A vaccine is given. 2 years catch-up vaccination if any vaccination has been missed out. Then 4 to 5 years, oral polio vaccine, the third dose, MMR, mumps, measles, rubella, typhoid, varicella for chickenpox, okay, diphtheria vaccine, these are given. And for 10 to 12 years, the human papillomavirus HPV vaccine is given for girls to prevent cervical cancer. So that's about the universal immunization schedule. I have not mentioned it that in the presentation, but in the textbook they have given it very vividly, so you can just go through it. That's about some programs affecting the child health nutrition.